Well, for our final talk of the morning, I'm delighted to introduce Dr. George Alba, who's going to be talking about post-intensive care syndrome, which touches on a lot of the topics that we've already covered this morning. So this is a perfect way to end this group of talks. A reminder to continue to pop your questions into the Q&A, and we'll have our question and answer directly after this. And Dr. Alba, thank you so much for joining us.
Thank you so much for the invitation. Good morning, everybody. So my name is George, as you've heard, and I'm a pulmonary and critical care physician here at Mass General. And this morning, I'll give you an overview of long-term outcomes after critical illness, a topic that's gained quite a bit of significance in the years following the COVID pandemic. My disclosures are unrelated to the content of this talk. So I will start with a case of a 46-year-old man with an elevated body mass index and type 2 diabetes who worked as a warehouse supervisor until he was hospitalized with ARDS from COVID and ultimately required a tracheostomy to successfully liberate from the ventilator. And his hospital course was complicated by ventilator-associated pneumonia, withdrawal from sedatives and analgesics, as well as delirium, muscle weakness, dysphagia, and sacral decubitus ulcers. So very common complications of prolonged critical illness. And at follow-up, when I saw him in our post-ICU clinic about 3 months after discharge from rehab, he reported shortness of breath, fatigue, short-term memory deficits, anxiety, and significant pain in his lower back and thighs. And consequently, he had not yet returned back to work, and his wife actually had to take a leave of absence in order to help care for him in his recovery. So his cross-sectional imaging at the time of admission to the ICU here is notable for diffuse ground glass and a pattern very typical for COVID pneumonia. And at follow-up, he had evidence of persistent reticular and some ground glass opacities in regions associated with traction bronchiectasis, suggestive of some residual pulmonary fibrosis. And his pulmonary function testing at the time of our visit showed a normal FEV1 to FVC ratio with a severely impaired FEV1 and FVC. And with the reduced total lung capacity, this pattern is consistent with severe restriction. He also had a very severely depressed diffusing capacity and indeed demonstrated exertional hypoxemia in the clinic and required supplemental oxygen. His flow volume loop is depicted here, really notable just for normal contours with a restricted pattern. And it's really important to review the flow volume loops in patients who had been intubated or had a tracheostomy because we can sometimes catch flattening of the inspiratory and expiratory limb of the flow volume loop. And in this separate case, it was actually a patient who was also hospitalized with ARDS due to COVID, but had a tracheostomy and ended up having central airway stenosis and required thoracic surgery to resect and reconstruct the trachea. So with this case in mind, I want to just ponder a few questions that we'll return to at the end of the talk, which are really how common are these persistent physical, cognitive, and psychiatric sequelae after surviving critical illness? Which hospital complications are most associated with developing long-term cognitive impairments? And what interventions, if any, have the best evidence for improving long-term outcomes after critical illness? So by the end of the talk, my goal for you is to be able to define what is meant by chronic critical illness and post-intensive care syndrome and how they're distinct from initial acute critical illness, understand the impact of both chronic critical illness and post-intensive care syndrome on patients, their families, and society more broadly, and how health inequities can actually worsen outcomes, and identify strategies for prevention or mitigation of post-intensive care syndrome in our patients. So historically, we have really viewed critical care and recovery as an acute event that either patients succumb to their critical illness or hopefully they gradually recover and ideally return to their baseline level of functioning, or at least close to it. In the modern era, we are very good at caring for critically ill patients. In this particular study of over 500,000 ICU admissions in the US over 2 decades, basically what you see is that hospital mortality has steadily decreased by about 35% over time, despite a slight increase in age over time and a significant increase in the severity of illness over time. And notably, this decreasing in-hospital mortality is associated with, in turn, an increase in the proportion of ICU survivors that get discharged to skilled nursing facilities and a lower proportion that get discharged home. So we have to kind of redefine our schema of critical illness and recovery to account for this increasing population of complex patients that include the chronically critically ill, basically patients who survive their initial bout of critical illness but require prolonged organ support. And those patients who ultimately leave the hospital but experience these constellation of long-term symptoms experience what we call post-intensive care syndrome. And so, a more formal definition, the term chronic critical illness was actually first coined in 1985 and really described patients who survive, again, their initial bout of critical illness, but really required ongoing intensive care. And while there is no formal definition, it's generally agreed upon that chronic critical illness is basically a disease state that's defined by prolonged mechanical ventilation, typically beyond 10 days, that's often associated with additional organ dysfunction and can last weeks, months, and up to years. Whereas post-intensive care syndrome really refers to those who leave the hospital and experience new or exacerbated health disorders that are common amongst ICU survivors that really persist beyond hospital discharge and involve three primary domains of the physical, cognitive, and psychiatric domains. Between 5 to 10% of patients who require mechanical ventilation in ICU for any acute condition, whether medical or surgical, develop chronic critical illness. And patients who are chronically critically ill will often undergo procedures like tracheostomy, gastrostomy tube placement, as well as things like renal replacement therapy. And in this population that require prolonged support, a small minority of chronically critically ill patients, estimated to be around 11%, are functionally independent at 1 year. So the vast majority require assistance at 1 year. This is from a New England Journal review of chronic critical illness from 2023. And this is a very detailed slide, but I wanted to say that besides ventilator dependence, chronic critically ill patients have a number of complications. And just to review a few, these patients can experience significant weakness attributed to things like myopathy and neuropathy, alterations in their lean muscle mass and body composition, brain dysfunction, anywhere from coma to protracted delirium. They can also have endocrinopathies because they have loss of the typical pulsatile secretion of the anterior pituitary hormones, leading to impaired metabolism. They're more vulnerable to infections, often with multi-drug resistant organisms, and they can experience things like skin breakdown, which can be exacerbated by nutritional deficiencies, anasarca, incontinence, and their prolonged immobility. And this obviously can result in quite a bit of stress to patients and their caregivers, as we'll review. So what is special about this 10-day mark that we use to arbitrarily define critical illness? So researchers have tried to basically empirically describe the transition from acute critical illness to chronic critical illness. And this is from a study of 1 million ICU patients. They basically looked at how well severity of illness at the time of admission to the ICU predicts mortality. And this is basically based on their diagnosis and using commonly accepted scores like the Apache score. And then they compared it to their pre-ICU baseline characteristics, their comorbidities and age and all those types of things to see how well it predicted their mortality. And what you can see is that in the early phase of acute critical illness, the severity of illness at presentation to the ICU is a better prognostic indicator compared to patients' baseline pre-morbid characteristics. However, at around 10 days, what you can see is that the pre-ICU baseline patient characteristics actually become better predictors of long-term mortality compared to that initial acute critical illness. And so this is why investigators conclude that around the 10-day mark, you go from acute critical illness to chronic critical illness, which then is better defined by the patient's pre-morbid functioning. And what they see is that this is true across a number of critical illness subtypes, whether you're in the cardiac ICU, the neuro ICU. 10 days is around the time where the acute critical illness tends to resolve, and their pre-ICU baseline morbidity tends to associate better with long-term outcomes. Researchers have also developed tools to help clinicians prognosticate clinical outcomes for patients who require prolonged mechanical ventilation, i.e. are chronically critically ill population. In this particular study, they looked at patients, in this case, requiring mechanical ventilation for more than 2 weeks, so a little bit longer than that 10-day definition. But what they basically did was they developed a multivariable model that was very highly accurate for predicting 1-year mortality in this data set. And the most predictive variables in this particular study were age, with higher age obviously associated with worse outcome. And in this case, they assigned a higher value to patients who were aged greater than 65. Thrombocytopenia, the use of vasopressors, and the need for hemodialysis. And you can see that if you have a score of 0, your 1-year mortality is estimated to be fairly low at around 20%. but your mortality rapidly increases as you accrue additional organ dysfunction. And so, as an example scenario, let's think about a patient that you may commonly see in the ICU, over 65, that's requiring prolonged mechanical ventilation and is still requiring vasopressors and dialysis. Their 1 year mortality is estimated here in this particular case to be about 100%. And so there are obviously many flaws with this model, and no one prognostic model should solely guide clinical decision making. But I think it's a sobering reminder that patients with chronic critical illness face poor outcomes and very limited chances of functional independence. And so these things can help guide discussions with patients and their surrogate decision makers around what their values are and preferences for care. I'll just conclude this section on chronic critical illness by just highlighting a study that looked at long-term outcomes among our chronically critically ill patients that undergo very common procedures like tracheostomy and gastrostomy tube placement. Um, and again, these are often used to help get patients off continuous sedation and attempt rehab, but there are various reasons why they may be pursued in our chronically critically ill population. And what you can see is that the minority of patients are discharged home who undergo these procedures. They spend most of their days in institutions, not at home, and they have a very high 90-day mortality and 1 year mortality, with between 60 to 65% dying by 1 year. And so outcomes are obviously going to be heavily influenced by patient level factors, especially again, pre-ICU baseline comorbidities. And if you look at patients that had poor pre-ICU baseline function, so frail, chronic organ failure, cancer, their mortality is going to be higher if you institute these procedures. However, if you're younger and more robust without these issues, the mortality is much lower. And so I think, again, thinking about when to pursue trach and a G-tube in these patients that are chronically critically ill, their pre-ICU baseline functioning is going to be really important for these conversations. So now let's just transition over to post-intensive care syndrome, which is, again, what ICU survivors face after their acute care. It was first formally defined by the Society for Critical Care Medicine not too long ago in 2012. And again, it's formally defined as a new or worsened impairment in one or more domains, including physical functioning, cognition, and mental health that persists past hospital discharge. And we'll go into each of these domains in more detail, but the range of symptoms that people will typically experience that have PICS consists of things like shortness of breath, weakness, impaired mobility, impaired sleep, memory impairments, and depression, anxiety, and post-traumatic stress disorder. It is estimated that about 80% of people who leave the hospital will have symptoms consistent with PICS, and up to 50% of ICU survivors will still have some of those symptoms out to 1 year. So substantial burden that can be unrecognized. It's important to recognize that PICS is not solely experienced by individual patients. It often will affect their families who take on caregiver roles, especially impacting their mental health. Between 25 to 50% of ICU survivors will require some degree of long-term family caregiver support. And in turn, this results in those caregivers experiencing new psychological symptoms, which is considered termed PICS family. And prevalence is very highly variable depending on what study you look at and at those first 6 months. But what was shocking was that in the COVID pandemic, PTSD rates doubled among families caring for loved ones who were critically ill with COVID. And that's attributed to a number of different things. But if you recall, there were significant limitations in family visitation, lack of family presence on rounds, and ensuing poor communication between the teams and families. Um, PICS and PICS family significantly impact families beyond their mental health and can have significant financial implications, as patients and their families will often experience high medical costs, job loss, reduction of income, loss of saving, and consequent housing instability that ensues. And in fact, if you look at this particular prospective study of ARDS survivors that were employed before coming to the hospital for the ARDS, about one half were jobless at 1 year follow-up. And among those who returned to work, about a quarter lost their jobs during the follow-up period. And about 70% of previously employed ARDS patients lost about $30,000 in the year after their critical illness. And on the right here, you see this graph of cumulative incidence of returning to work over time, broken down by younger or older age and being white and non-white. What you can see in this population is that older non-white survivors experience greater delays to returning to work. And this is one of the many disparities that are encountered by folks after critical illness. There are disparities that occur by things like insurance type, whereby those that are uninsured or underinsured can face limitations in the kinds of post-ICU rehab services that they can access, which in turn leads to worse long-term outcomes. Now, focusing in on the physical domain, we know very well what happens after you get ARDS in terms of the pulmonary sequelae. So on the right here, you see representative CAT scans of patients with ARDS at the time of their ICU stay, dense consolidations, juxtaposed to follow-up CT scans at 6 months. And what you can see is some residual reticular changes that lead to some that are consistent with some mild pulmonary fibrosis. And when you do pulmonary function testing on these patients, about half will have manifest with a restriction as a result of this, plus some of the respiratory muscle weakness. And impaired diffusing capacity on pulmonary function tests is one of the most common findings in these patients. The physical consequences of patients leads to, as I mentioned, a lot of neuromuscular weakness, and this can be manifested with activity intolerance. So you can see 6-minute walk distance is impaired at 3 months and improves by 12 months, but is still relatively impaired from their baseline. And when you look at longitudinal cohorts, and ask them, what is the primary driver of their impairment? It's really a lot of it is fatigue and muscle weakness as opposed to their dyspnea. But as you can see, the totality of these physical impairments is that it leads to reduced quality of life, preventing patients from performing their activities of daily living and being independent in some cases. The cognitive consequences of critical illness have been very well studied, and this was a landmark trial from over a decade ago now of over 800 ICU patients with shock and respiratory failure. And they underwent serial cognitive assessments in the year following surviving their critical illness. And what these researchers found is that their median global cognitive score, as assessed by this particular battery called the R-bands, was significantly impaired at 1 year. And at 3 months, almost half of patients had scores equivalent to individuals with traumatic brain injury, and a quarter had scores equivalent to individuals with Alzheimer's disease. And when you looked and saw the impact of delirium, what you find is that the longer duration of delirium is independently associated with worse global cognition at 1 year. And this is particularly notable because we saw quite a lot of delirium in our critically ill COVID patients. They often required multiple sedatives, analgesics to tolerate mechanical ventilation. And as a result, these patients have quite a bit of cognitive impairment after they're surviving the ICU. This is a kind of provocative way to look at this. This was a study that followed patients after surviving 6 months after hospital discharge, and they were asked to copy this figure, which is basically a test of visual construction known as the Ray Osterith complex figure test. And you can see that the patients have varying degrees of difficulty with this task. All these patients had no baseline cognitive deficits, but from the left, you see somebody who survived a PE to a pneumonia survivor to an ARDS survivor, and you can see a quite dramatic inability to construct this. Now, the psychiatric domain is also a significantly impacted area. The incidence of anxiety and depression can be as high as 50% in the year after ICU discharge, and as high as 25% for PTSD. And these don't exist in isolation. They will often overlap, and about half of patients have at least one or more domain impacted, have one domain impacted, excuse me, half have one domain impacted at 1 year, and about 20% or a fifth of these patients will have more than one domain. This is the patient that I had mentioned to you that brought these notes in with him. I thought they were interesting to just share. He vividly recalled thinking that the respiratory therapist was trying to cut off his windpipe, and he saw the dialysis machine in the room and thought it was a baby going through a blender, which are very striking images to have. And these perceptual disturbances are really common in critically ill patients and can lead, obviously, to post-traumatic stress disorder. This particular patient also had kind of an anxiety response anytime he heard car horns or phone chirps, because he reminded him of the beeping he heard in the ICU. So there are several known risk factors for post-intensive care syndrome. Some are non-modifiable, like age and pre-existing frailty, any pre-existing disability or cognitive impairment, and of course, the severity of critical illness cannot really be modifiable. There are some potentially modifiable risk factors, like how long the patient is mechanically ventilated, how long they're in the ICU, and the degree of shock and organ dysfunction. These are potentially modifiable factors. And then there are definitively modifiable things like our choice of sedation, which will directly impact the incidence of delirium, which again is something we discussed already, but it has a strong association with the degree of cognitive impairment that people experience. We can also modify things like mobility, the quality of sleep in the ICU, the degree of hyperglycemia, um, how we can, other things that we can modify are family presence. Again, isolation is something that a lot of people with COVID experienced and probably accounts for the significant increase in PTSD in both patients and their families. The most effective strategy for preventing PICS is really to prevent critical illness to the best of our ability. Things like immunizations, preventing communicable diseases, the use of things like non-invasive ventilation in patients with respiratory failure to avoid mechanical ventilation. But ultimately, mechanical ventilation, critical illness are not always preventable, and that's where protocolized care in the ICU with the ABCDEF bundle is really necessary. So the ABC refers here in this case to awakening and breathing coordination with light sedation, appropriate treatment of pain, avoidance of deliriogenic sedatives like benzodiazepine, and daily sedative interruption with breathing trials to try to see if people are ready to liberate from the ventilator. D refers to management of delirium, which is, again, a key risk factor for cognitive dysfunction and really hinges on preventing it through appropriate use of sedatives and detecting delirium through daily screening. And of course, implementing non-pharmacologic strategies to reduce the incidence of delirium, things like maintaining the sleep-wake cycle and having family present. The E stands for early mobility and physical therapy, which can begin as soon as it's feasible and safe for patients to, again, improve their physical functioning. And as this ABCDEF bundle, in addition to F, which is the family engagement, has been shown in various meta-analyses to either decrease mortality or at least decrease the incidence of delirium, the use of physical restraints for agitated delirium, decrease ICU readmissions, and decrease actually discharge to skilled nursing facilities. So really, protocolized care to achieve these things is really the backbone of preventing post-intensive care syndrome. Now, in terms of post-ICU clinics or PICS clinics, these were first introduced in the 1970s in the UK, and then they expanded globally in the years since then. And it's really in recognition of the need for patients and families to have this dedicated medical, mental health, and social support after surviving the ICU. And there are some data that suggests that they can be helpful, although it's kind of mixed as to whether or not there's any direct impacts on ICU readmission or mortality. In the US, PICS clinics really are generally associated with large academic centers and are dependent really on things like discretionary funding and provider volunteerism. There's not a lot of support for these clinics. Despite all of this, in 2021, this is Surviving Sepsis Guidelines from the Society of Critical Care Medicine does make a recommendation that ICU survivors follow up in some sort of post-ICU clinic within 2 to 4 weeks of hospital or rehab discharge, which in practice is not particularly realistic given the paucity of these clinics. There are also just several barriers to follow up in a PICS clinic. Some are patient level factors like age and severity of illness and disability prevent people from coming into the hospital. We've also seen that disparities occur in PICS follow-up, and specifically language barriers present a substantial burden. There are financial and environmental barriers that can include lack of insurance or the cost of transportation or the distance to the nearest PICS clinics. And again, many patients transfer from hospital to a rehab before returning home, which can decrease the likelihood of follow-up, particularly because insurance will put limitations on primary care follow-up and not specialty care follow-up while patients are in rehab. In terms of how to best to evaluate and manage PICS, there's really all expert guidance or not strong guidelines here. But they do recommend that every domain of PICS be evaluated in a structured fashion. Otherwise, more subtle impairments can be overlooked. And there are many studies show that things like primary care providers, who are often the point of contact for these patients, are just really not aware of what to look for in ICU survivors. And so for the cognitive domain, there's a battery of assessments that they recommend to screen for cognitive deficits that range to things like the use of the Montreal Cognitive Assessment or the mini mental status exam. For the physical domain, they recommend a review of the ICU course to get a better sense of what kind of physical complications the patients experience, particularly things like airway complications, if there was prolonged intubation or tracheostomy. They also recommend assessing the cardiorespiratory system with things like spirometry and 6-minute walk testing, especially for the ARDS survivors, um, and various other physical assessments to get a sense of physical weakness and ICU-acquired weakness. And for the psychological domain, they recommend using inventories like the Hospital Anxiety and Depression Scale to screen for depression and anxiety um, and post-traumatic stress disorder. I will say that in standard clinical practice, outside of a dedicated PICS clinic with a multidisciplinary staff, it's really not feasible to run a battery of tests that will take just an hour in itself to administer to each patient. So what I would say is in my own practice, what I've adopted is a more parsimonious approach to screen for PICS. So in the appropriate patient that is at risk for PICS, I'll generally do something quickly like a MoCA, which again screens for cognitive impairments. If somebody has visual impairments or you're doing it over the telephone, then there is a MoCA blind assessment that eliminates the visual portions of the test, so you can provide it to visually impaired or over the phone or over telehealth. Um, and that's pretty much the extent to what I will do. If there's family concerns of cognitive impairments, I will refer, and we'll talk about who to refer to in a moment. In terms of the physical assessment, I generally will get pulmonary function tests and 6-minute walk tests. And if abnormal, they may prompt additional testing, but generally these provide an objective marker to follow over time as patients recover from their critical illness and undergo rehabilitation. And finally, for the psychiatric domain, I will use something simple like the PHQ-9, which is a really quick screen for depression and anxiety. And if they screen positive or they also have symptoms of PTSD, then I'll consider more in-depth assessments if I have time. But generally, at this point, I will be referring for assistance. In terms of treatment, what's recommended by expert opinion for the cognitive domain is really to identify any reversible causes, such as new medications that may have been started. For instance, a lot of people get started on antipsychotics in the hospital to address agitated delirium, but they probably do not continue to need antipsychotics in the outpatient setting. So anything that can help impact cognition should be assessed. Looking for sleep disordered breathing or other impairments in sleep-wake cycle, identifying underlying psychiatric conditions. Obviously, in older patients with depression, they can manifest with pseudo-dementia. And of course, trying to identify any metabolic or nutritional disturbances that are impacting cognition. After addressing these reversible causes, then things like referral for cognitive therapy through certified speech language pathologists or occupational therapists can be helpful. For the physical domain, physical rehab with physical therapy, OT, pulmonary rehab are all very effective. Physical medicine and rehabilitation evaluation can also be super helpful if patients have persistent musculoskeletal impairments that could benefit from more detailed evaluation or potential interventions. And from the psychological domain, referral to psychiatry, cognitive behavioral therapy, use of pharmacotherapy for depression, anxiety, and PTSD, and even referral to peer support groups, which do exist in most cities, can be helpful for patients. And in practice, this is what I will generally do. I will generally refer my patients to speech language pathology for the cognitive therapy piece of things. And most patients at that point find that it can be helpful, especially if they had a high level of executive functioning prior or have to return to work where there's a high level of executive functioning. The cognitive therapy piece can be helpful. There is, of course, more in-depth neuropsych testing that can be done. We have that available here, but that is not always available everywhere. For the physical piece, most people by the point that they're seeing you will have had PT and OT. But if they haven't, then of course, very much important to refer for either outpatient or home-based therapy. And then, of course, referring to pulmonary rehabilitation is very important for these patients, particularly our ARDS survivors that have impaired lung function and may require supplemental oxygen and have physical weakness. Again, if they have significant pain, joint stiffness, musculoskeletal symptoms, PM&R can be very helpful. And finally, for those who screen positive for symptoms of anxiety, depression, and PTSD, this is where referral to psychiatry, or at least looping into their primary care, can help for managing these patients. So to just return to our case, he completed pulmonary rehab and actually was over time was able to come off of daytime supplemental oxygen. His pulmonary restriction and impaired diffusing capacity did improve over time, but never fully resolved due to the residual pulmonary fibrosis that he manifested. In terms of his persistent fatigue, one of the things that we did for him was screen him with a sleep study, which diagnosed him with untreated, undiagnosed obstructive sleep apnea, and he was started on nocturnal CPAP, and he experienced significant improvements in his daytime fatigue. He completed cognitive therapy with SLP, and I did refer him to PM&R, and he ended up having massage therapy, acupuncture, and trigger point injections, which significantly improved his pain and stiffness. And he and his wife were ultimately, after 1 year, were able to return back to work. So going back to the questions that I posed at the beginning of the talk, um, persistent physical, cognitive, and psychiatric sequelae are indeed very common after surviving critical illness. And up to 80% of patients will experience PICS at hospital discharge, and up to 50% will experience PICS at 1 year following their index ICU admission. Delirium and duration of delirium are the most strongly associated risk factor for long-term cognitive impairments after surviving the ICU. And finally, the intervention with the best evidence for preventing and reducing PIC severity is the implementation of, again, a protocolized care with the ABCDEF bundle in the acute ICU care setting, which again protocolizes strategies to minimize sedation, decrease duration of mechanical ventilation, prevent and mitigate delirium, increase early mobility, and again, encourage family presence in the ICU to help both patients and their families better understand what to expect during their ICU stay and expect after their ICU stay, which is often the piece that I feel like we do not provide always great counseling on. And as critical care providers, especially those of us with any outpatient clinics, we're uniquely poised to help care for these patients and their families in the outpatient setting. And I would say that this has made me definitely a better ICU doctor. So thank you so much for your attention, and I'm happy to take any questions.